Okay, I gotcha.
Okay, I think you're good. You need to turn
Oh,
on
it's
your
10.
mic.
All right. Everyone quiet. I'm going to be lecturing to you today about selecting lipid-lowering pharmacotherapies. Lipids and cholesterol is something that I've studied for a very long time, actually about the past 10 years, and it's been a topic that's been near and dear to me. I've studied it both clinically from a standpoint of investigational medicine and in the laboratory as well. There's a huge overlap with the increase of cholesterol and coronary artery disease, and that with obesity. And as you all have heard, obesity, depending exactly on how you define it, can be well over 50% of the population, probably closer to 65% of the population now. And so this is the incidence of this disease is actually goes up all the time, and that's despite the best efforts as clinicians to keep it down. So this is actually a pretty critical lecture, just because so many people are burdened with atherosclerosis. So I encourage you to pay close attention to this, because it's more than likely, actually it's essentially 100% certitude that you're going to be in contact with patients that are affected with hypercholesterolemia. I've studied this from three different perspectives, and from pharmacology, what they call the big three, both at the university setting, at drug research setting, commercial drug research setting at Pfizer Inc., and then finally with the Food and Drug Administration. And before I actually start digging into this, I want to tell you a little bit about what this is, in case you haven't seen this title before. That's the PharmD title. So this is a doctorate that was developed within about the past 50 years or so, when it was predicted, and correctly so, that one day the number of drugs and drug-drug interactions would overwhelm physicians and nurses in the hospital setting. So this is a clinical pharmacy degree. It's a doctor of pharmacy degree. This degree is similar in the sense to the medical degree, is that after the 4-year program, you can go specialize in just about any specialty the physicians can. And my specialty in particular was that in vascular medicine, where I went. I used it to go do research. Anyway, let's get started. Whoops. There we go. So I've detailed a few of the abbreviations here in this first slide, and these are abbreviations which you're going to want to familiarize yourself with. You can't run away from them. The objectives here you guys have, they're just as stated. Hyperlipidemia is something which is a broad term, which includes hypercholesterolemia. Refers to elevated blood levels of lipoproteins, which can include cholesterol, triglycerides, and phospholipids. And the abnormalities can include one or more of the following: elevated LDL, elevated triglycerides. And triglycerides aren't actually a form of cholesterol, which is why the slide is titled hyperlipidemia. Triglycerides are a form of fat storage in the body. Reduced high-density lipoprotein, which is, as you know, the good cholesterol, and elevated total cholesterol. The standards, the levels of these drugs are set by the National Cholesterol Education Program, NCEP, Adult Treatment Panel, which is on its 3rd revision now. CAD, or coronary artery disease, refers to plaque occlusion in the arteries and the heart. And approximately 50% of American adults have high levels of LDL. Unfortunately, according to pharmacoepidemiologists, less than 50% of the patients who do have high LDLs are receiving lipid-lowering treatment, despite all of pharmacies' and physicians' best efforts. Hyperlipidemia is not the only cause of coronary artery disease, but it's probably the strongest predictor of coronary artery disease, as shown in the literature. And hypercholesterolemia is something which gives additive risk to the non-coronary artery disease risk factors, as you've heard already: cigarette smoking, obesity, hypertension, et cetera, including in addition to ECG abnormalities. Just a quick note on ECG. I've underlined it here because a lot of people use the acronym ECG or EKG, and they actually do mean the same thing. But actually, the acronym EKG is the German acronym because they spell cardiogram with a K. And so ECG, the ECG was actually an American invention, and the correct acronym in the United States is ECG, not EKG. Just for those of you who like the sticklers for grammar. Atherosclerosis is responsible for 43% of the U.S. deaths and nearly all heart attacks and 80% of strokes. Lipid levels aren't a perfect predictor by themselves, but LDL levels are still considered an independent predictor of morbidity and mortality. So therefore, again, even if you don't know if somebody is hypertensive or a smoker or obese or has diabetes, just the fact that their levels, just one simple laboratory test that tells you their laboratory levels of LDL are elevated are grounds enough to initiate a treatment of some sort. Despite what you may think kills most people in the United States, more Americans die of coronary artery disease and stroke each year as compared to cancer, accidents, or any other causes. So again, as I said in the introductory slides, lipids are a very serious business, and hopefully I've made my point. Depending on the what kind of different genetic disorder one has, oh, that's not right. There we are. Depending on what kind of a different genetic disorder one has, they're going to express a different type of lipid abnormality. Type 1 lipid abnormality is going to be elevation in chylomicrons, which is a genetic LPL deficiency. Type 2A, which is going to be the main focus of this lecture, is going to be an elevation in LDL cholesterol, also again called the bad cholesterol. And 3B is going to be elevation in LDL and VLDL. VLDL is actually the main carrier apolipoprotein of triglycerides, so you can use them synonymously for the purpose of this lecture. There's actually one kind of lipoprotein I haven't listed here. Can anyone tell me what it is? There's 6 of them. Which one? Who said that? Who did? All right, good job. Just because you guys answer the questions correctly here, I want you guys to pay attention because I know you don't get a break and you're full of atherosclerosis, so I'm going to give something away to anyone who answers it correctly. It basically amounts to random things that have made my way into my office and or candy. So the next slide is actually an expanded version of the next slide is an expanded version of what I've made in the previous slide. What I've done here is I've listed in the 2 columns to the right the first choice of therapy, of pharmacotherapy, and then the second choice and third choice in the appropriate order. In some ways, this is a good slide that you're going to want to be familiar with because in some ways it's a summary of the entire lecture that I'm giving you today. In addition, I've also listed the combination therapy if the first line treatment is intolerable to the patient or they need additional pharmacotherapy. And so elevated LDL is the most common and is the most atherogenic. So we're going to be focusing on elevations of LDL cholesterol first. Increased serum LDL is largely due to increased HMG-CoA reductase activity, and increased HMG-CoA reductase will produce more cholesterol within the body. It also can be due to a decreased LDL receptor synthesis. The less LDL receptors there are on the liver will mean that plasma LDL will not as readily be taken up and broken down by the liver. The fate of circulating cholesterol can be eliminated within the enterohepatic pool, or it can also be eliminated within the stool. And the problem arises when there's excess cholesterol in the body, that unmetabolized excess LDL can be oxidized and accumulate in the arteries, as you've seen in Dr. Favre's lecture. And this is something which takes about 40 or 50 years to occur. So when one talks about atherosclerosis, they're really talking about a cholesterol storage disorder. But in addition to being a cholesterol storage disorder, it's equally a disease of inflammation. And this is something I actually didn't realize until I was partway into my vascular medicine research fellowship. And what happens is a little bit of cholesterol will stick within the coronary arteries, and the body kind of doesn't know exactly what to do with it, and so it treats it it treats it kind of as an invader, and it produces an inflammatory response. So a little bit of cholesterol will stick there, and then a whole bunch of the body's inflammation responders will stick to that, including interleukin-6, TNF-alpha, and there's a whole cornucopia of these inflammatory markers. I'm not going to burden you with them all. Basically, and actually most importantly, because there's no drug in which to treat them. One of the things that holds us back in pharmacology right now is all we can really treat is the lipid production, not the inflammatory response. Now, I know what you're thinking. You know, there's lots of anti-inflammatory drugs you can take out there, naproxen and ibuprofen and aspirin, but it's been shown in studies that those don't quite hit the right kind of inflammation that's caused within the coronary arteries. So yeah, just recognize that it's that we're really one of the problems of why we can't really treat this disease completely is because we're not treating the inflammatory component. And a lot of the pictures you see, the cartoon pictures which they show regarding atherosclerosis, where they show this red coronary artery and then like a thick yellow fatty plaque in the coronary artery, is actually really not accurate because it's many different kinds of cells that cause atherosclerosis to occur and accumulate. So in the treatment of hyperlipidemia, statins are going to be the best choice. But before you initiate statins, I'm obligated to tell you about there are therapeutic lifestyle changes which have to occur. And I know you guys have already heard about this, so I have no intention of dwelling on it. But most of them are going to be dietary and exercise in nature, and we'll just leave it at that. If a therapeutic lifestyle change fails, drug therapy would start at any point when LDL levels are above 130 milligrams per deciliter. So why is lowering LDL the primary goal of pharmacotherapy? Well, it's because the LDL carries most of the cholesterol in the body and actually carries somewhere between 60 and 70% of the cholesterol that goes through your body. And so LDL cholesterol, because it carries that much, is considered to be the best predictor of death and cerebrovascular events. And the more coronary artery disease risk factor a patient has, the more stringent of an LDL goal they're going to need. Now, I didn't really emphasize it too much in the slide because I don't want to burden you with too much knowledge from the literature here. But there are actually some of the strongest pharmacological literature out there involves the giving of statins to lower LDL levels and prolong one's life. And there are dozens and dozens of clinical trials which have shown this. And again, it's some of the strongest pharmacological literature out there. And those trials involve literally hundreds of thousands of patients. Now, I've already talked to you. You've already heard a lot about the risk factors here, so I'm not going to dwell on this too much either. But of the constellation of risk factors, depending on whether you're male or female for HDL cholesterol levels, you basically begin treatment. The modifiable risk factors include LDL, where you begin treatment again at 130 milligrams per deciliter. If one has hypertension, type A personality, diabetes, estrogen status, you know anyone with a type A personality, physical inactivity, something called abdominal obesity. Are you familiar with the term abdominal obesity? Okay, good. And also cigarette smoking. And I'm gonna go off on a little bit of a tangent here with regards to cigarette smoking, because there is a big difference clinically if one were to smoke 1 cigarette a day and 40 cigarettes a day. But in either case, it's considered to be a risk factor. Smoking is actually a very dangerous habit, which counts as an independent risk factor for heart disease. And even if one were to stop smoking completely, it takes 3 years for the cardiovascular risk to disappear. And the cancer risk stays around indefinitely, depending on how the body is able to eliminate the chemicals within cigarettes. Smoking is even dangerous to people who don't smoke. The smoke that comes off a tip of cigarette is more dangerous than the filtered secondhand smoke, which the smoker consumes. In one study in particular, a very poignant study, in Colorado, smoking was banned in all places of business, and 2 years later, the cardiovascular event rate went down by 30%. And so cigarettes and burning tobacco are a very dangerous substance, and there's an overwhelming amount of data which agrees with me on this topic. Anyone has more questions about that, I'm happy to fill their ear after class. And so again, for any kind of lipoprotein disorder, you want to do therapeutic lifestyle changes, and this is stuff you've already heard about. The bottom line is it's exercise and diet, like I said. These diets, though, really aren't that bad. It's not just a complete awful diet of eating just leaves and tofu all day long. Even the American Heart Association allows for some junk food to be taken in the diet. Anyone want to guess how much of your diet is allowed to be junk food according to the American Heart Association? Just shout out some numbers. What's that? No. Do it as a percent of calories over a month. Assume like someone were to have a 2,000 calories per day, so over a month that's 60,000 calories. So what percentage would you think? Wait, who said 10? Raise your hand. Who said 10? Who did? There? All right, you said 10? All right, you got it. Let's see what I got for you. I have a stock bottle of Lipitor for you, 80 milligrams. It's for you or a hypercholesterolemic friend or family member. And no joke, this bottle contains 90 pills, and it sells for $540.36. Come get it after class. You better get it now, actually. Yeah. Just relax. It's filled with Skittles, so don't worry. So yeah, 10% actually. 10% is actually it's a decent number. The problem is that Americans and people who are obese and hypercholesterolemic don't eat junk food in moderation. So if you assume again a 2,000 calorie a day diet, that's going to be 6,000 calories a month. But the problem is that people can have those 6,000 calories and they have it all in one day, or they have it in a couple of days, and then they repeat it again the next day. And so that's what the problem is. The problem is moderation. People don't consume the